Hello and welcome to Key Insights of the 2016 European Focus on Myeloproliferative Neoplasms and Myelodysplastic Syndromes. My name is Srđan Verstovšek. I'm the Professor of Medicine in the Leukemia Department at MD Anderson Cancer Center in Houston, and I'm joined with my co-chair of the meeting, Dr. Professor Alessandro Vannucchi from Florence in Italy. Good morning, Alessandro.
Good morning, Serge.
Now, this was a meeting spanning over 3 days in 4 different sessions, and we started here with the first session on biology of NPN and MDS, particularly focused, I would say, on these overlap syndromes of chronic myelomonocytic leukemia, on atypical chronic myeloid leukemia, and others. It was very informative, novel findings in the biology of these diseases that soon enough will lead us to new therapies. We have discovered new mutations that drive these processes, and we had nice speakers that summarized those for us. I think these are one of the real important discoveries in past year for us. Wouldn't you agree, Alessandro?
Yeah, for sure. We have to consider that CMML is a difficult disorder to diagnose. It's a rare overlap syndrome, and it is characterized by 2 different, let's say, population of patients with very aggressive disease and patients who have, at the end of the story, a smoother disease. And so the data that have been presented have clearly put in light that there are novel mutations that may be very helpful for diagnosing the disorder, but especially to make prognostication, because we know that some mutations including specifically AZXL1, but also, of course, mutations of TP53 are very important for making prognostication of the patients. And we also have learned that there are differences in the immunophenotyping of monocytes in these disorders, and actually this kind of approach might be very useful for making diagnosis in these patients. So this is clearly a moving field. What is still missing, we have to acknowledge that, is an effective therapy for these patients.
I agree with you. I think the biology appears to be way ahead of our ability to utilize that information for drug development. However, I think the direction is great. We really make strides in discovering new targets for development of therapy. And Dr. Mario Cazzola, in fact, summarized for us mutations in splicing genes that are important in myelodysplastic syndrome, particularly in the areas of ring sideroblasts, where particular mutations appears to be targetable with new biological agents, and there is enthusiasm and high expectations of such phase 1 studies that are coming along.
Yeah, of course, in the case of ring sideroblast MDS form, we have a mutation, SF3B1 mutation, that is very specifically associated with the disorder. So it's clearly important for diagnosis, but it's clearly also a link to the pathogenetic mechanism, and so it will for sure facilitate the development of new drugs in this field. There are also some evidences that have been presented in the last month that JAK2 inhibitors may be effective in this kind of disorders. So this is not a frequent entity, but it is important also to distinguish it from other forms. For example, this is maybe true when we have this MDS form associated with thrombocytosis that may be easily missed as an ET rather than an MDS. And of course, this is important in terms of management, expected complications, and eventually also in treatment.
The last 2 talks of the biology session were very intriguing. We had a talk on what I would say seed and soil theory, the microenvironment of the bone marrow predisposing or contributing to a disease evolvement. And then there was a summary of hereditary versus predisposition to myeloproliferative neoplasms or myelodysplastic syndrome, where we are learning new views of what actually matters. It's not just about mutations, as we discussed. It is also the microenvironment. It is about genetic background of the individual that leads to a disease. We don't really know how, but this environment and the background appears to be as important as is the presence of certain mutations.
Oh, this is absolutely true. You made really two great points. The first one is about what surrounds the cells of the clone, because of course it's clear that the disease originates in the hematopoietic stem cell, and this is clearly shown by the acquisition of mutations. But we are learning how important is the environment in which this clone is actually living within the bone marrow, but very likely not only in the bone marrow. So there is a component of cytokines. This is one, I think, of the most important things that we have learned in the last years about the impact of inflammatory cytokines that are important not only for the clinical manifestations of the disorders. And we have to say that we have learned this from the impact of JAK2 inhibitors that tampered down the level of these inflammatory cytokines. But there is evidence that these cytokines, growing evidence, that these cytokines are important also for the maintenance of the clone and maybe also for the expansion of the clone. And the second point is that we are starting to appreciate the role of other cells in the pathogenesis of disease. So fibrosis is clearly one of the most obvious components of myelofibrosis, and there are models, murine models, that have been studied in the last years that have shown the impact of some cytokines, such as, for example, TGF-beta, on the pathogenesis of fibrosis. We know that it is a reactive process, but there are now new data suggesting that also cells of the stroma might actually be involved in some genetic abnormalities. And at the end of the story, we still do not know what kind of cells is exactly the one producing fibrosis. So may not be the usual stromal cells, but it might be also a transition form of a cells that changes its phenotypes and is activated to produce fibers. And finally, the role of endothelial cells is also a field of active research, possibly for the contribution to one of the most common clinical events in these patients, that is thrombosis. And as to the second point, this is also a very appealing field of research. We know that on the background of the same mutation, let's say JAK mutation or KR mutation, the phenotype of the patients may be different. And so there might be other components, other genetic components that predispose to one rather than to the other phenotype. But even more, we now know that there are genetic components in the predisposition to these disorders. So there are families, well-known and well-characterized families with MPNs, but apart from these families where some mutations have been described in the very last times, including duplication of some genes in a brilliant work made in a French family. But we know that there are genetic predisposition factors that involve the whole population. These are represented, the first to be discovered is the 46/1 haplotype in the JAK2 gene. But now we know that there are other haplotypes, other genetic variations that are found in the population that are associated with an increased risk of these disorders. I think that one important point is how to use this information in the clinical practice, because patients ask whether these are genetic disorders, where their sons should be typed for this genetic background. And of course, at the time being, nothing of this should be done in a healthy individual.
So the biology section was really exciting, as you summarized it very well, in our ability to learn biology background of different types or subtypes, if you like, of these diseases. And the clinical applicability has to be developed in the right direction. We are discovering such a rapid pace where there is some lag behind applicability, like you said, in the everyday practice. However, we do witness now a genetic influence on our diagnostic criteria. The WHO classification of hematological malignancies, particularly for MPN, has been recently modified to incorporate some of the genetic information to bring about an understanding of that, plus the histology, and not just the clinical observations. So Dr. Tiziano Barbui has summarized this for us. This was recently published, where we were learning about the concept of for example, prefibrotic myelofibrosis, as distinction from the essential thrombocythemia, role of bone marrow biopsy in the diagnosis of PV, to be able to distinguish masked PV from the overt PV. So we are refining the diagnostic process as well. When we come to therapies, it seems that there is enthusiasm in two directions when we talk about therapies for myeloproliferative neoplasms. Development of novel, better, super long-acting interferons, where interferon has been traditionally used in some patients with MPN, and branching out use of JAK inhibitors beyond just advanced myelofibrosis into ET, PV, and perhaps even early-stage myelofibrosis. Particularly, I think you have been involved in early-stage myelofibrosis, where there are some studies going on right now. I think this is very novel approach to prevent things from happening rather than wait for things to happen. How do you see that?
Well, I see like a very exciting field, as you mentioned. This is an hypothesis that we want to test experimentally using the drug, using well-selected population of patients. So the hypothesis is that based on what we have learned from the use of JAK inhibitors in advanced myelofibrosis, we could delay the progression of the disease into more advanced phase if we start early in the treatment. And to do this, we internationally have planned a trial that is based on the selection of patients with early myelofibrosis, so small spleen, very few symptoms, but a category of patients that is expected to have a high risk of progression based on their mutational profile. So data suggests that presence of some mutations in genes such as ASXL1, SRSF2, EZH2, and IDH1 and 2 may point to a group of patients who are at increased risk of early death and risk of progression to leukemia. So the basis of this trial, that is called the RETHINK trial, that will be an international trial, is that if you treat early with a JAK inhibitor, ruxolitinib, this group of patients, you can delay their progression in terms of worsening of spleen, worsening of symptoms, and eventually hematological progression. So this is really a very exciting trial. It will provide important information for the clinics, but it will also provide very novel, very important information in terms of understanding the biology of the disease.
And the development of therapies for ET and PV, essential thrombocythemia and polycythemia vera, has been also a cornerstone of debate here, particularly with the exciting developments of this super long-acting, this is the interferons that are given every 2 weeks now that are being developed, particularly here in Europe for PV. It seems that early intervention with interference biological agents in PV and possibly even in ET in near future will impact on the evolution of the disease and prevent perhaps the transformation rate that we see and the thrombotic events. On the other hand, it appears that there is a role, as we already know, for a JAK inhibitors in advanced PV, where one of them has been approved recently, and perhaps in the future in advanced ET. So we are, it looks like to me, filling the gaps and finding the proper therapeutic approaches for different populations of the patients. It's not one fits all.
I agree, Serge. So these are two different molecules, interferon, as you mentioned, and the JAK inhibitor, that are still now have been used in different setting of patients, because the JAK inhibitor has been used in the response trial in patients who are refractory or intolerant to hydroxyurea, while the new interferons are being used especially in patients with polycythemia vera in let's say common forms of disease not resistant to other drugs. So particularly for interferon, this is an old drug with an old story, I would say, but of course these are novel molecules, so they might be better tolerated than conventional interferon, and they might provide benefits to the patient. So it's very important that we are waiting for the results of the first phase 3 trial in patients with polycythemia. with interferon. And the results of this trial will clearly set the stage for this kind of treatment that is widely used in some countries, even in Europe and the United States. But we also have to remember that the drug has not received approval for the treatment of these disorders, and so things might change after the data from this phase 3 trial have been produced.
Now, as we learn a lot about biology of the disease and that we discussed, which influence now the diagnostic process, particularly MPN, we and others are very excited about applicability for development of new drugs, but also for prognostication and selection of the patients for different therapeutic, particularly talking about bone marrow transplant interventions. So there were 2 talks, one on and the nice summaries of the utility of the genetic profiling in MDS as well as in MPN for everyday practice. And here is where I did discordance, quite a bit of a discordance between our ability to test for and then make decisions or direct patients beyond the just referring to bone marrow transplant. Beyond that, we don't have too many options. So in MPN in particular, and MDS perhaps a little bit less, that is so obvious. How do we make the strides here? What actually needs to happen?
Well, stem cell transplantation is till now the only curative option for both kind of diseases. But you are right in saying that the knowledge that we have obtained in biology of these disorders, mainly through study of mutations, have not yet translated into clinical applicability in terms of stem cell transplantation. So the criteria for suggesting stem cell transplantation to a patient are still based on clinical aspects of the disease, not yet on molecular basis of the disease. I will just discuss what has been found in myelofibrosis, because I think it's very explicative. So we know that some mutations may be prognostically negative in patients with myelofibrosis managed with conventional treatment. In particular, I'm referring to the so-called group of triple negative patients who are not mutated for JAK2, KRAS, and MPL, where this negative impact of this mutational profile is still maintained after stem cell transplantation. So clearly, this is not, will not result as a criterion for selecting or not a patient to stem cell transplantation. Yet we know that even this kind of therapeutic approach will not be able to modify significantly the prognosis of these patients. And the same is for MDS, where clearly the situation is more complex because of the even greater genetic heterogeneity of the disorders.
So 2 aspects of utility appears to be happening. Prognostication, perhaps some therapeutic decision-making in terms of referral to transplant, both in MDS as well as in MPN. But then we had 2 summaries from the transplant point of view, how to use for therapeutic management of the patients that are going through the transplant, how to use genetic information, introduction of the specific inhibitors, donor lymphocyte infusions, and the outcome of the transplant on its own based on the background genetic complexity or presence of certain mutations, like in MDS, presence of P53s, bad prognostic factors. But beyond that, we had a series of reviews by experts in the field on utility of JAK inhibitors in myelofibrosis, combination studies that are happening right now in advanced myeloproliferative neoplasms based on the JAK2 combinations, novel JAK2 inhibitors that are coming along. And on the same level, we had reviews on the use of novel agents in myelodysplastic syndromes beyond the hypomethylation agents. The last topic that I felt was quite novel is the extension of our appreciations of a quality of life improvement in myeloproliferative neoplasms as a target for new drug developments along with other benefits, where now we had a very nice review of quality of life improvements in myelodysplastic syndrome as a target for drug development along with other benefits, improving blood cell count, for example. I think that the movement from looking at just the bone marrow and the blood count to a person and quality of life is quite valuable.
Yes, this is important because we, as you said, we are moving from just treating the disease to having the patient at the center of our actions. So this is an emerging field in MDS. We have, I would say, more experience in MPNs, especially with the use of JAK inhibitors in myelofibrosis, where one of the main endpoints of treatment has resulted also from the phase 3 clinical trials is the improvement in symptomatic burden, is the improvement in quality of life. So clearly this is a balance between hematological efficacy of drug, overall toxicity, but at the end of the story, what we are really starting to appreciate is how much these novel agents that are not able yet to cure the disease may improve the life of a patient without creating toxicities, of course.
I think the mood has changed because of the movement that you are describing, looking at the person and making chronic disease that still affects the quality of life and shortens life expectancy to much more chronic, prolongation of life with a good control of the disease signs and symptoms, perhaps without even elimination. So the view of what these therapies may produce and what is the overall goal of therapy has changed to chronicity with a good quality of life. I think that is something that we have learned from MPN very well, and now is moving to other chronic diseases. I am excited of a change in view what needs to be done. It's not all about complete remission. If you can really achieve it, at least you can make people live longer with a better quality of life. So I thank you very much for a lovely discussion. These were key insights from a 2016 European focus on myeloproliferative neoplasms and myelodysplastic syndrome meeting that was held in Zagreb, Croatia. Thank you very much. I hope you join us next year for the next version of 2017 focus on MPN and MDS. Thank you.